Okay, so the first specimen is coming from a 76-year-old female. This is a ureteroscope washing cytology specimen. So we received two specimens from this patient. The first one is coming from the left ureter. So because it is a washing specimen, we expect to see like a hypercellularity, and some of the cellular are in fragments instead of just like individual cells. So this is common that we can see in the washing cytology specimen because of the washing force. We would expect to see like cells in fragments. So this is a hypercellular specimen as expected. So the key diagnostic point is to identify cytomorphological feature of a high-grade urothelial carcinoma. So in this specimen, we can see most of the cells have like enlarged nucleus with relatively polymorphic nuclei and irregular nuclear membrane. And most of the cells have these very hyperchromatic chromatin. And the chromatin pattern is actually, you can see there are some coarse, like a granule within the nucleus. So this is coarsely granulated. Additionally, you can appreciate that NC ratio is markedly increased. So we have cells with only very a very small ring of cytoplasm. So this is diagnostic for high-grade urothelial carcinoma. So for the washing cytology specimen, sometimes it is a little bit difficult because we will see a lot of fragments and it is a little bit difficult to see through. However, for these specimen, it is kind of easy because you can easily appreciate that these high-grade nuclear atypia of these urothelial cells, and these are throughout the entire specimen. So this is positive for high-grade urothelial carcinoma. We also received the renal pelvis washing from the same site. So for the renal pelvis washing cytology, the typical cells are not as common as what we see in the ureter, which means it is likely the lesion is actually inside the ureter, not in the renal pelvis. However, when we do the pelvis washing, we can still appreciate they were scattered high-grade cells with hyperchromasia, coarse chromatin increase, NC ratio, enlarged nucleus. So these are also diagnostic for high-grade urothelial carcinoma. For the urine cytology, it is important that we identify the individual cell with high-grade atypia. Sometimes the aggregates of the cell can have some change that is indefinite, but it is important that we can identify all of these features in the individual cells. So these are positive for high-grade urothelial carcinoma. So then we move to body fluid specimen. The first one is coming from a ascites specimen of a 64-year-old female. So according to the history, the patient has been proven to have gastric cancer and has been proven to have liver metastasis. So on low power for this body fluid specimen, we noticed they were scattered like a tight cluster of cells with hyperchromasia. So these are what we call the second population. So we will usually go to higher power to confirm the nuclear feature. So for this cluster, you can appreciate that we do have a few larger cells with irregular coarse chromatin and the prominent nucleoli. The shape of the nucleus are all very different. This is triangular, this is oval with a little bit irregularity over here, and they are in a tight cluster with some lymphocytic infiltration. So this is consistent with metastatic adenocarcinoma. So again, in this cluster, you can appreciate very tight glandular three-dimensional structure with a luminal border. So this is consistent with adenocarcinoma with these high-grade nuclear atypia. So the history is gastric cancer. The cytomorphology is actually not very specific for gastric cancer. We only can tell that this is high-grade adenocarcinoma. We also receive a cell block preparation. In this cell block preparation, the tumor cells are more frequent than the cytospin preparation. So you can appreciate that cluster of cells with glandular like a feature with a luminal border, and the nucleus are all very pleomorphic and atypical. So this is consistent with metastatic adenocarcinoma in the ascites specimen. So the next specimen is coming from pleura effusion. So this is a very typical case of metastatic lung adenocarcinoma in the pleura effusion. So as we know that lung cancer is probably the most common cancer. So in here in Taiwan and probably in the East Asia, Southeast Asia as well. So we frequently will see these type of specimen. So because the specimen was like prepared on Monday, and usually on Monday we will change our staining solution. So it is a little bit too dark in the nucleus. So you need to know the chromatia of the benign reference cell first. So here is the mesothelial cells and histiocyte, a little bit darker than usual. So it's probably because they changed the solution. So this is our normal chromatia now. So you always need to go to the reference cell in the background. And then we start to notice that they are some cluster of cells with three-dimensional architecture and which much bigger nucleus comparing to the adjacent normal cells. And it's also a little bit darker, but it's kind of difficult to tell because everything seems to be very dark. So in our lab, usually we would want to have a staining pattern that in the normal cell population, the chromatin is less darker than this one. So when we see a malignant cell cluster, we can appreciate the true hyperchromasia. So try to turn down your hematocrit stain if you can. Yeah, so for this specimen, we do a cytospin preparation. Apparently, the specimen itself has a lot of the cell. So when we do the cytospin, we would try to smear the specimen as a more like a flattened monolayer sheet. So apparently in this specimen, it can be a little bit sticky, so the smearing was not very successful. Hence, we do not appreciate like these cell cluster can be as nicely demonstrated as it should be. However, we also have a cell block preparation. So in the cell block preparation, it is very easy. You can appreciate these are all tumor cells. Most of them were tumor cells. And this is actually very typical for lung adenocarcinoma if it has a predominant micropapillary pattern, which is a high grade, like a more aggressive histological pattern in the lung cancer. And you can see this type of pattern in the predominantly in your pleura effusion specimen. Okay, so even though the cytospring preparation was not very successful, so the next time try to smear it into more like a monolayer smear, but our cell block preparation is like very successful, so we see a lot of tumor cell here. So this is positive for adenocarcinoma, and we can use the cell block preparation to do here. We will first do EGFR molecular testing because the positive rate is around 50%. So if the EGFR turn back to be negative, we will proceed for our NGS testing. So the next specimen is also pleural effusion specimen. So the patient already had the history of lung adenocarcinoma, proven to be EGFR positive, and this is suspect to have the recurrence of disease. So you can appreciate the cytomorphology is very different from what we just saw. The more well-differentiated adenocarcinoma will form cluster. But here we only see individual single cell. So this is a sign suggests that it already developed like poorly differentiation. When you go to higher power, you can appreciate the nuclear, typical nuclear atypia of a poorly differentiated adenocarcinoma. So the chromatin pattern we will describe as vesicular. Here is not very like prominent because our stain is a little bit too dark, but you can appreciate the chromatin pattern, and you can appreciate there are like a smaller, like a pale area, white area, suggest like we call this vesicular pattern. And most of the cell has prominent nucleoli, and most of the cell do have the eccentric nuclear location. So this is a typical cytomorphologic feature for a poorly differentiated adenocarcinoma. So in the in the cell block preparation, you will also expect to see these cells are all presented as mostly as individual cells and with polymorphic nuclear features. So these are positive and consistent with recurrence of the patient's treated lung adenocarcinoma. Okay. So again, pleural effusion, lung cancer. So again, the patient has been treated. So we only see like individual cells with very big nucleus, like prominent nucleoli, eccentric location. And here we can appreciate what we call vesicular chromatin very clearly. So you can see there are like a smaller vesicle within the nucleus. So this is a typical morphologic feature of a poorly differentiated adenocarcinoma. So you can see these are vesicular. And the nuclear contour can be quite irregular. So you see a big notch over here, another notch over here. So these are consistent with poorly differentiated adenocarcinoma. The patient also had a history of lung cancer and has been treated. Okay. So this is a new patient. '83-year-old male, and presented in our hospital with pleural effusion and shortness of breath. So on low power, you can already appreciate that we do have very tight and dark cluster of these smaller cellular aggregates. So this is a very typical presentation of a primary lung cancer. The initial specimen usually looks like this. So lung cancer most common here, and 50% of the cases when we identify the cancer in the patient presented with advanced disease, which means with pleura effusion and cannot have like a surgery. They need to have systemic treatment already. So we will see this type of specimen in half of our lung cancer patient with pleura effusion. Looks like this. So this is very typical. So what we do here, whenever we see these specimen, we would have a cell block preparation. And because this is the very first specimen, and we will check the tumor cell is positive for TTF1, suggests that it is coming from the lung. This is lung primary. So let's take a look of the cell block here. So this is our cell block preparation. Again, it has a like a reverse micropapillary type of pattern, and which is very typical for our lung cancer patient. So here we have enlarged nucleus, vesicular chromatin, cherry red prominent nucleoli arranged in a tight glandular structure. So we will do a TTF1 scan to confirm that the patient indeed the tumor is coming from lung, and then we would do EGFR testing for this patient to see if he is eligible to the EGFR TKI. So we have a lot of lung cancer today, so I'm not going to show every case. So this case has a different history. This is a 76-year-old male. He has a history of pancreatic ductal adenocarcinoma. And this is his pleura effusion specimen. So in addition to pancreatic cancer, he also had a history of prostate cancer. So it's getting more and more common in our patient to have two different types of cancer. So again, in the body fluid specimen, we want to search for tight aggregate as the second population. So here we identify a tight cluster. So most of the cell has hyperchromatic nucleus and arranging a very tight three-dimensional like a cellular cluster. The nucleus is kind of polymorphic, so you can appreciate that each of the cells have a different appearance. So this is consistent with metastatic adenocarcinoma. So if you want to tell by the morphology whether this is coming from the pancreas or this is coming from the prostate, the best that you can tell is that usually for the pancreatic cancer, you will expect that you can see some intracytoplasmic mucin vacuole. So this is more commonly that you can see in the prostate, in the pancreatic cancer. For the prostate cancer, usually the nucleus will be more uniform instead of these highly polymorphic pattern. And usually they will form small, like a rosette type of pattern. And it is not common, very uncommon, you can see prostate cancer go to the body cavity. So these, just by the cytomorphology, we think this is more likely to be coming from the pancreatic origin. So this is positive for adenocarcinoma and likely coming from the pancreas origin. So then we move to some fine needle aspiration. This is coming from thyroid. So when we interpret finding the aspiration of thyroid, the first thing we want to check is if there is any colloid in the background. So here we identify this specimen with a very clean background. We do not see any colloid, but we do see hypercellularity. And most of the cells are aggregates into these either monolayer fragments, monolayer sheets, or a more complex, sort of like a papillary type of uh, architecture. Additionally, on this low power, we can also appreciate the presence of multinucleated giant cells. So here is also a multinucleated giant cell. So just based on this low power view, no colloid, hypercellularity, the arrangement we see are like monolayer sheets and papillary type of architecture. So we suspect it is a papillary thyroid carcinoma. So what we need to do is just to go to higher power to confirm the nuclear atypia of a PTC. So here we can appreciate the cells are enlarged and mostly are in oval shape. And if you draw a long axis of each of these cells, you can appreciate that these axes are all crossing with each other. So we realize this is actually a disorganized arrangement, disorganized pattern. And then we start to appreciate there are some like a vague groove. Perhaps this looks like a pseudo inclusion, a groove over here, maybe a few grooves over here as well. So the nuclear feature do show features of papillary thyroid carcinoma. Sometimes not very easy to identify a good pseudo inclusion. But here you can see this cell do have a notch over here and this sort of like an inclusion over here. What we call pseudo inclusion is actually represent of invagination of nuclear membrane. So here we have a big notch, and if we see it in a different like angle, you can see the pseudo inclusion inside the nucleus. So the nuclear feature do consistent with features of papillary thyroid carcinoma. So here again, you see the long axes are all crossing with each other. So these organizations, some overlapping, and a lot of grooves here and there. So this is very typical for a papillary thyroid carcinoma. I just want to show you the feature of multinucleated giant cell. So this is a multinucleated giant cells. So giant cell is very frequent that you can see in PTC, but remember it can also be present in the setting of thyroiditis. So this is a multinucleated giant cells. These are PTC cells. And this is multinucleated giant cell as well. So the case is diagnostic for papillary thyroid carcinoma. So next specimen is coming from a neck lymph node. So in this specimen, first of all, we do not see lymphoid tissue, lymphoid cells in the background, but we do see a lot of histiocyte. So this is actually a cystic background. Whenever you encounter a lymph node aspiration with a very cystic background, it is abnormal. It is not normal. In the head and neck, the most common scenario is that it does has a cystic metastasis, and the most common origin is coming from the papillary thyroid carcinoma. So the patient actually came to our hospital because he found there's a nodule in the thyroid. So the clinician do the sono and identify a tumor within the thyroid. Plus, they are some lymph node with cystic change. So they decided to aspirate the lymph node instead of the primary thyroid nodule. So we pay attention to the background, we realize that these are cystic, this is abnormal. So we will search for aggregates of epithelial cell. And so what we see here is very similar to what we just saw in the thyroid aspiration. So this is the represent like a cells of papillary carcinoma. So you can appreciate the nuclear inclusion here and there. So we do identify some epithelial cell here. So this is consistent with our expectation. So for the cystic change, sometimes we will see this type of cells looks very much like histiocyte. And sometimes it can have some aggregation. So it is a little bit uncertain whether this is a true histiocytic origin or this is actually coming from the tumor cell with cystic change. So we would describe these type of cells as atypical histiocytoid cells. If this is the only cellular component that we see, and we might not be able to directly call these positive for metastatic carcinoma. So again, if the tumor cell have a cystic change, the most common change is enlarge of the nucleus, and the nucleus will become rounded instead of elongation. So you will see large rounded nucleus, sometimes with pseudo inclusion, and additionally, the cytoplasm will also be like more abundant, sometimes with a lot of vacuole, and looks a little bit like histiocyte. But because we see the pseudo inclusion, this is consistent with metastatic tumor cell. So this is consistent with cystic change of papillary thyroid carcinoma cell. So for this lymph node, we will send it out as positive and consistent with metastatic papillary thyroid carcinoma because we identified the typical nuclear feature. So the next specimen is also coming from thyroid. So again, thyroid aspiration, first we want to know, do we have the colloid in the background? So we don't have the colloid in the background, so that means that the specimen, there might be some problem of the specimen. So on low power view, it is not very cellular, but we can appreciate like a small, very tight cluster of these cells, sort of arranged in a microfollicular type of pattern. So we have a very clean background, follicular cells arranged in very tight cluster and without nuclear feature of a papillary thyroid carcinoma. So all of these cells are rounded small with a condensed chromatin pattern and arranged in a small, like a microfollicular type of pattern. So the pattern is suspicious for a follicular neoplasm. So usually when I diagnose follicular neoplasm, I would check the sonography feature of this nodule. So I check the sono, it is a very big nodule and it looks like it is a follicular tumor with a rounded contour and hypervascularity around this nodule. So this is consistent with follicular neoplasm. So we will send out the case TBS category 4, suspicious for follicular neoplasm. So finally, we have a few pap smear. The first is coming from an 84-year-old female who has received total hysterectomy due to high CO. So the patient has been diagnosed with a precursor cervical lesion, which means that she has HPV infection. So after total hysterectomy, we still sometimes would do pap smear for the follow-up reason. She is very old, And it is not uncommon in our population to have pap smear from an 80-year-old female. I don't like it, but they do it, yeah. But anyway, because we know the patient do have the past history of high CO, so we know that the HPV can actually also infect the vagina squamous mucosa. So for this case, so we don't have cervical mucosa, only the vagina mucosa, which is commonly to have more superficial cells. And so we identify some superficial cell, enlarge in the size of the cells, remain low NC ratio. The nuclear is hyperchromatic comparing to the adjacent intermediate cells. So again, we have binucleation, multinucleation, and the flank hyperchromasia comparing to the adjacent intermediate cells and with coilocytic change. So these cells are quite frequent, especially we are using the conventional smear here. So you would expect if it is a focal lesion, the lesional cell will be on the same smearing like a direction. So this is a typical like a pattern that we will see in like a precursor lesion in our conventional pap smear. So we will sign it out as LOCIO. So this is a LOCIO case from the vagina. So next, 57-year-old female. So she has a history of precursor lesion. So about 1 year ago, our pap smear diagnosed LOCIO, and she has been proven by biopsy with LOCIO. So she keep follow up in our hospital. After the diagnosis, she also received HPV testing. So she has like a multiple HPV genotype, type 16 plus positive for other high risk, non-specified other high risk genotype. So she had multiple genotype infection. So again, if we are like interpret the conventional smear, if it is a focal lesion, you would expect that it is on the same smearing direction. Okay? So here we start to see, yeah, so we see definitely hyperchromasia, coarse chromatin, enlarged nucleus. The NC ratio is actually still low. It's lower than like a usual typical high CO cell, right? And it is within the cluster of intermediate type of cell. We do not see a flank like coilocity change. So this is actually intermediate between the low CO and the high CO. And in the old time, we call this CIN2. So this is a typical case of CIN2. We still report CIN2 here. So along the smearing direction, yeah, we can identify individual cells. Again, hyperchromasia, enlarged nucleus, coarse chromatin, and slightly decrease of NC ratio, but still have quite some cytoplasm. And here, again, large cell, hyperchromasia, irregular chromatin pattern, and the NC ratio is not very high. So this is like very typical for CIN2, which is still a high CO. So we would sign the case as CIN2. And the clinician also repeats the HPV 1 year after. And I just got the result. She still have persistent type 16 and other high risk HPV. So still, she has persistent infection. And because she got type 16, this is highly likely that the lesion can progress from low CO to high CO. So we would call this case as CIN2. So that's for all the case today.
Thank you.
Thank you.
Thank you, sir.